Welcome back to RX Russia Pharma Basics. I am Dr. Russia, and today we are diving into one of the most clinically important drug classes in cardiovascular and renal pharmacology, diuretics. In this episode, we are covering two of the most commonly used subclasses, loop diuretics and thiazide diuretics. By the end of this video, you will understand how they work, when we use them, and what to watch for. Let us start with loop diuretics. Loop diuretics act on the thick ascending limb of the loop of Henle in the kidney. They block a transporter called the sodium-potassium chloride cotransporter, or NKCC2. By blocking this transporter, they prevent sodium, potassium, and chloride from being reabsorbed back into the bloodstream. The result is that a large amount of water follows these solutes into the urine. This makes loop diuretics the most potent diuretics we have. The classic example is furosemide, also known as Lasix. You will also hear about bumetanide and torsemide. So, when do we use loop diuretics? The number one indication is fluid overload. Think acute decompensated heart failure, pulmonary edema, cirrhosis with ascites, and nephrotic syndrome. We also use them in certain cases of hypertension, especially when the kidneys are not functioning well. Now, what about side effects? Because loop diuretics flush out electrolytes along with fluid, the biggest concern is hypokalemia, which is low potassium. This is dangerous because it can trigger life-threatening arrhythmias. We also watch for hyponatremia, hypomagnesemia, and metabolic alkalosis. Another important side effect is ototoxicity, especially at high doses or with IV administration. Patients can develop tinnitus or even permanent hearing loss. Always monitor renal function and electrolytes closely. Now, let us move on to thiazide diuretics. Thiazides work at the distal convoluted tubule. They block the sodium chloride cotransporter, also called NCC. Because this segment reabsorbs less sodium compared to the loop of Henle, thiazides produce a more moderate diuretic effect. The most commonly used thiazide is hydrochlorothiazide, often abbreviated as HCTZ. Chlorphalidone is another one you will see frequently, and it actually has a longer half-life, which makes it preferred in many guidelines. The primary use of thiazides is hypertension. They are actually a first-line treatment for uncomplicated hypertension, particularly in certain patient populations. They are also used for mild fluid retention and in patients with calcium kidney stones, because thiazides actually decrease calcium excretion in the urine. Side effects of thiazides include hypokalemia, just like loops, along with hyponatremia, hyperuricemia, which can trigger gout, and hyperglycemia. So use them carefully in patients with diabetes or gout. Thiazides can also cause hypercalcemia, which is actually the opposite of loop diuretics. Loops increase calcium excretion, while thiazides decrease it. That is a classic exam comparison worth remembering. One more important point: thiazides lose their effectiveness when the creatinine clearance drops below about 30 milliliters per minute. In patients with significant kidney impairment, you need to switch to a loop diuretic. Let me leave you with a quick summary. Loop diuretics are your heavy hitters. They work at the loop of Henle, cause massive diuresis, and are used for fluid overload conditions. Watch for hypokalemia and ototoxicity. Thiazides work at the distal tubule, are milder, and are the go-to for hypertension and calcium stones. Watch for hypokalemia, hyperuricemia, and hyperglycemia. And remember, loops increase calcium loss, thiazides decrease it. In episode 4b, we will cover potassium-sparing diuretics and carbonic anhydrase inhibitors. Make sure you are subscribed so you do not miss it. This is Dr. Rasha, and I will see you in the next episode.